On behalf of the Center for Cross-Cultural Research and the Department of Psychology, I want to thank you for being here tonight. I'm Anna Chow, for those who don't know me. I'm the current director of the Center for Cross-Cultural Research. We are a group of students, faculty, and staff here at Western who do and think about and support each other in cultural research activities. One of those activities is bringing amazing speakers to campus so we can learn together from folks outside of Western. And I want to make sure to thank the Alumni Association for co-hosting tonight and advertising the event. I'm really delighted to introduce our speaker, Dr. Kelsey Okamura. She is a friend and a colleague that I admire very much. Dr. Okamura is an implementation researcher at the Baker Center for Children and Families that's affiliated with Harvard. She is living and working in Hawaii, however. Her team is doing innovative, cutting-edge work, trying to get access to youth mental health interventions, working with community members and other champions to make sure that youth who need support are getting it. We're really lucky to be able to learn from her today. Please join me in welcoming Dr. Okamura.
I keep thinking that it's morning, but it's not. It's evening or afternoon for you folks. So thank you so much for having me here today. And hai sai kusio, aloha mai kako. I'm going to be talking to you all about community-led implementation strategies in youth mental health. This will highlight a compendium of work that I've had the privilege of developing and working with in some of the communities in Hawaii and across the continental US. So awesome, this is working. A little bit about me. These are some institutions and agencies that I've had the honor of working with over time. My research is really focused in on youth mental health, psychopathology, implementation science. My training is in modular cognitive behavior therapy and integrated behavioral health, and I've done a lot within rural mental health as well. Quick disclosure, I am a paid consultant for PracticeWise, and that's a for-profit agency organization that aims to synthesize existing youth mental health knowledge in order to make actionable tools for the therapists and communities that need them the most. All right, here is our agenda. I'm a good CBT therapist, so I start everything with an agenda. Does anybody recognize this road? No. Diana. It is. It is. It's the road to Koloa. Amazing. Yes, this is my favorite tree tunnel in Kauai. And it's often something that I like to reflect on as we kind of drive through, reminding me that, you know, there's always kind of a nexus. There's something that we're kind of going towards. And I like to think that, you know, that's what our agenda is going to do. So I'm going to talk a little bit about kind of the public health scientific problem, you know, why we call it implementation science, defining the thing, and talk a little bit about some of the research that we've done. But before we get into that, just to center and ground ourselves, because I recognize some familiar faces and unfamiliar faces, I want us to kind of take a moment and think about and imagine a world that has absolutely no suffering. There is no adversity. You are doing what you love. I want you to imagine this world. The problems that you have quick and easy solutions. There are no disparities on who receives these solutions, and they're all individualized to your unique needs. What are you doing in this world? Where are you? What is your family doing in this world? I want you to keep that world in mind as I kind of go through the next round of slides, because that really kind of centers us in, you know, some of the work that our team has been, you know, really passionate and involved in is really trying to create this world kind of this imaginary world where, we can provide access and provide youth mental health services that work for the people who need them the most. Okay. Other important thing, contextual thing, talked about this a lot. If you guys were in the methods talk earlier, or I got to, talk story with you a little bit, really important to who the work that I do is centering around who I am as a person. So you can see here, Diana probably knows where this is too and who I am. I was like, no, I have no idea. I think maybe Anna's parents know what this is actually. Okay. But who I am, I'm a mother of 3. I have a 9-year-old, a 5-year-old, and a 4-year-old. I'm a 4th generation Okinawan Japanese daughter of immigrants to Hawaii. I grew up in Waipahu, Oahu, which is a plantation town. I'm a psychologist. I'm an implementation researcher. I'm a soccer and a taiko player. Not as good as a soccer player as Anna, unfortunately, but decent. I could keep up with her. I could defend her. So you can see, thinking about kind of who I am, there are many different contexts and very different social dimensions that influence what I study, who I am, and what position I bring to any community that I do this work in. So just want to situate that. You're getting my side of the story with these dimensions. I'm sure if you ask anybody else who is involved in this team or who is receiving the services or, part of our focus groups, they might have a different story. All right. So the goal of my research, big picture, is to improve the lives of youth suffering from mental health disorders. And what we know about youth mental health is that by age 18, at least 20%, 1 in 5 youth will experience some kind of behavioral health or substance use concern. Oftentimes in the community, youth will receive little or no care informed by the evidence base. And as treatment efficacy or kind of randomized controlled trials or scientific trials continue to rise, we're seeing more of a gap in terms of the extent to which we're getting those treatments into the community. There's also major events that happen in our society, like COVID-19, or other natural disasters that may have affected you or your loved ones or people that you work with, that impact kind of the general kind of well-being and the communities that you see. And that really heightens the mental health need. And so when we think about it, when we think about the classic research paradigm, we have a lot of really good people doing really good research, studying these things in randomized controlled trials or very kind of structured settings. And we have the community doing really great work trying to deliver these treatments, right? But we see that we have kind of a pipeline issue, right? That issue of getting that science into the community, that has, and that takes a lot of time. And that is the focus of a lot of the work that we do within implementation science. It's fairly typical, and you hear this quite often, that it takes about 17 years, 15 to 20 years, 17 years to get research into practice. And that starts with initial funding, initial pilot and feasibility studies, all the way into translational studies in the community. It takes a really long time. My kids aren't even that old. And so when you think about it, it does, it's a long, ongoing and iterative process. And this is a picture of Charles Lynn, James Lynn. He studied scurvy in naval ships. And he actually, he has a connection to Hawaii. I always like to try to find connections to Hawaii. It's my favorite thing to do. And so he actually went to Kealakekua Bay in one of his voyages. But he was the first person to kind of conduct a clinical trial where he separated sailors who were experiencing symptoms of scurvy and treated one group of sailors with citrus in order to, help with the condition, and another group with nothing at all, and found that the citrus was really helpful in, increasing health and, prolonging death, not prolonging death. That was wrong. That was incredibly wrong. In circumventing death. And so that was done in 1747. It was finally implemented as standard routine practice in the Navy in 1794. That's a 47-year gap. And so when we think about implementation science, we're thinking about how are we kind of getting the thing into the settings that we need them most. Oftentimes in youth mental health, you'll hear terms like evidence-based practice or evidence-based treatment. And that can describe any kind of innovation. And when we're thinking about implementation science, that's really kind of at the heart of what we're doing. We're identifying an innovation that has been studied, has some kind of empirical science or empirical findings that support its efficacy, and we're trying to get it into the research setting. And so you might hear other terms that are related to implementation science around effectiveness trials, where we're trying to control conditions in the community under which we would deliver these services. Not quite implementation research because we're still pretty structured, but what implementation research does is studies how to promote that evidence-based innovation, like how to promote the thing. So this is a fun little infographic talking about the thing. We're always trying to do something, the thing. And this gives a kind of breakdown of the different types of studies that you might do that are related to implementation science versus effectiveness research versus other kinds of translational research. Lots of different terms in our field. So when we think about evidence-based practice, especially for youth mental health, we often think about a lot of different interventions. We might think about treatments. We might think about the actual practice or like a kind of process. In fact, when we look at, kind of the definition of evidence-based practice from the American Psychological Association, it's often described as kind of this three-legged stool, an iterative process of integrating the best available research evidence, clinical expertise, and patient preference. So very different from something we're thinking about that has been studied in a randomized controlled trial, right? And so it's going to bring me to a problem, the real scientific problem, I would say, with regard to trying to get mental health treatments into community settings for youth. But in order to illustrate that, I have to tell you a story. I'm going to tell you the story of Keith. This is Keith. He's my partner. We have 3 children together. He is a social worker. We have a lot of feelings about social work in our home. I often say that I wish I was a social worker, and he thinks that is incredibly offensive coming from a psychologist. But I would say that social workers are such great systems thinkers. They get trained in such a different and completely unique and complementary way. Okay, so this is Keith. Keith is actually a social worker, licensed clinical social worker. And so he is newly licensed. He is working for a new agency out in the community and is very excited about delivering mental health services for youth. It's something he's been wanting to do since grad school. And so he wants to find all the available information on youth mental health. So where does he go? Casey, he goes to Google. He goes to the Google machine, right? And he types in his question, ADHD resources for therapists. Because he knows, because he's a smart social worker. He knows that there's going to be a lot of youth that he sees with ADHD. And so he wants to find the best available treatments. Look what he finds. I can't even read that number. 80 million resources in less than a second. That's a lot of resources, right? That's a lot of information. And so what does Keith do? So Keith is he's very, he's a critical thinker. I'll give him that. He's clearly a good thinker because he's, anyway. So he brings up, kind of the top 3 results, compares them side to side. Look at him, he's so tech savvy. He can look at, 3 web pages at once. And he's looking at them and he's realizing, well, I don't know how to synthesize this information. There's so much different information that I'm looking at. And what does Keith do? He closes his computer in frustration and yells a profanity as our kids are sleeping. And he's just frustrated, right? And we see that often with this idea of evidence-based treatment. This is a study we did in 2019, was recently cited by the National Academy of Sciences, that looks at the growth of treatment for youth disruptive behavior relative to the practices over time. So when we're thinking about treatment, sometimes we see treatments that come in manuals. You'll get this shiny book and it's super cool, and you put it on the bookshelf and it just collects, dust. So all of those manuals, right, they're comprised of specific practices. And what we did in this study was look at all the different practices and found that while treatment manual growth continues over time, the actual practices, and this is consistent for a lot of youth mental health problem areas, they asymptote. They seem to level off over time. And a lot of the, and they do that for all the different problem areas, and they seem to be shaped by different, federal priorities. We see changes with regard to traumatic stress related to, emergence of the National Child Traumatic Stress Network and congressional acts that really kind of appropriate funds related to certain problem areas. So we're seeing that across the board, right? Not only in the Google machine for Keith, but even in our literature, we're seeing that there's this growth of treatment protocols or manuals, but not a lot of growth in terms of practices. And similarly, when we're thinking about evidence-based treatments, often we think, well, as you sit here, trainees, students in graduate school and undergraduate school, that there's going to be consistency in what you are learning at the undergrad level and the graduate level, and then across the various programs, right, that give the same degree that you're about to receive. And so another study we looked at was, trying to understand the extent to which accrediting bodies use the term evidence-based practice. Why is that so important? If we're saying that evidence-based practice is, the bee's knees and has to be used with youth mental health, then you better be learning about that in graduate school and in your training, right? And a lot of things that are governed, in your curriculum are based on standards and accrediting bodies. And what we found, and this is a cognitive phenomena, there's a phenomenon called the jingle and jangle problem. Have folks heard about the jingle and jangle problem? So the jingle problem is when there's something that researchers use the same word to refer to different constructs. So evidence-based practice, there's definitely a jingle problem. My idea of what evidence-based practice is, if we would look at that 3-legged stool, might be very different from what Alex is thinking, what Anna is thinking, what Casey's thinking, Diana, like there's so many different ways of thinking about it. And then the jangle problem is when there are 2 identical or almost identical things that are labeled with different things. So we hear that a lot when it comes to methods. We heard that earlier. There might be terms around decolonizing methodologies or critical indigenous methods, right? That kind of similar, but different words. So this jingle and jangle problem. And what we found in our review of accrediting standards was that for EBP definitions, evidence-based practice definitions, there's not a consensus, even in accrediting bodies. And that has implications in terms of how we're training, what you're learning, and what we're expecting of in the community when we're thinking about youth mental health, right? So I'd argue, and this is something that continually I grapple with, and which makes me very excited about the work that we do, is that the real scientific problem is not that we can't get the treatments into the community. The real problem is that there's an oversaturation of knowledge. There's just too much information out there, and there's not a good way for us, me as a person, therapist in the community, to decide which thing that you're going to use. And we need coordinated knowledge management systems in order to really kind of make those decisions for therapists, to make it very easy for them to choose the right solution, right? So I just went over this, but the idea then is to make these tools as user-friendly as possible. And that's a lot of what implementation science does. So this is a seminal definition by Eccles and Mittman in 2006, noting that it is the scientific study of getting the thing and studying those methods in the community. There was a recent review by Wang and colleagues in 2023, which is now indicating recent review. There was a review this year, a scoping review of theories, models, and frameworks in implementation research. And they found that there was over 143 different theories, models, and frameworks. Again, an oversaturation problem. But one guiding framework that I've used a lot that we use a lot in our research is the Consolidated Framework for Implementation Research. So this is a figure right here, developed by Laura Damschroeder and colleagues in 2009, which conceptualizes implementation across several different domains. So the intervention itself and the characteristics of the intervention, the individuals involved, the people actually delivering the intervention, the inner setting, so that could be your agency, it could be your school, it could be your classroom, anything that kind of directly, very close touches the innovation itself. And then there's the outer setting. So things related to policies that could be happening at your complex level, your state level, federal level, that impact the extent to which you can implement something. And then the actual process of implementation. So this framework was developed in 2009. It was updated just recently in 2022 based on user feedback. The domains and the definitions remain conceptually the same. There's just more nuance in terms of the applicability to actual applied implementation. But just know that this is kind of the way by which I conceptualize implementation research, which is important as we start to think about the work that we're doing in youth mental health. So again, here's the CFR. If we're thinking about Keith, there's a number of different things. Oh, shucks. You can't see the top one. But there's a number of different things that Keith is thinking about related to these CFR domains, right? So in terms of the process, he might be thinking, oh, I got trained in the thing. At the top, there's outer setting. And something that might come up is our agency gets reimbursed for the thing. The intervention itself, the thing works for my client. And in the inner setting, my supervisor provides a lot of support to do the thing. So again, thinking about all the different kind of contexts, these domains, and how they affect implementation gives us a robust and many options of how we're going to study implementation for youth mental health. So I grabbed this directly from our website, our Implementation Research Division website. We have four major let me start that one again. We have four major overarching aims to our work. And I'm going to go through and highlight some of the work that we have been working on, some of which excitingly have not been presented anywhere yet, that will be presented at the Association for Behavioral and Cognitive Therapies later this week. So thanks to the co-authors, and I'll give them a shout out as we go through it. So the first one is related to advancing health equity to promote the well-being of Indigenous groups. So a lot of the work that we have been doing with regard to understanding youth mental health in Hawaii state is to understand the impact of historical and intergenerational trauma on overall well-being. So one of my colleagues, Danielle Carrera-Ching, almost Dr. Carrera-Ching, has been doing a scoping review. This is a poster that was presented at the American Psychological Association annual convention, where she's been looking through a number of different studies to see how historical trauma has been defined in the literature for Native Hawaiian populations. What's really interesting here is that she's uncovered almost 33,000 different articles and has had to go through them individually to kind of sort them out. That's the whole scoping review method. But again, when we're thinking about that oversaturation of information, that oversaturation of knowledge, we have a lot of information, and we continue to increase that knowledge. And we're trying to develop tools in order to kind of synthesize that knowledge. So still work underway. We're in kind of the full text extraction right now, and I'm excited to see kind of what she finds with regard to how historical trauma has been defined for Native Hawaiian populations. It's the first scoping review, to my knowledge, that's being done. Okay. The other thing that we've been very excited and been working on for many, many years, I joined the team a few years ago, but this work represents at least 2 decades of community engagement with rural Hawaii schools, relates to the Ho'ounapono drug prevention curriculum. So this is a culturally grounded substance use prevention curriculum that was developed with middle school students in rural Hawaii. And so it's been developed through 5 consecutive National Institute on Drug Abuse grants to develop, pilot, test the efficacy, understand the implementation, and now update the curriculum for electronic nicotine devices. And so the intervention has demonstrated sustainment of youth resistance strategies, as well as to decrease cigarette and e-cigarette use 6 months after the intervention in a follow-up efficacy trial. So again, when we think about this intervention, a teacher-delivered intervention, we're faced with another kind of research to practice gap, right? So on the one hand, we have this really great intervention, culturally grounded nonetheless, right? Developed with youth and families. But we still need to get it into the classrooms. We need to spread it on a more kind of robust level. And so we've taken a multi-method and several-year approach to setting implementation here. So we've done in-depth individual interviews with 24 people who have delivered the intervention. From that, we develop a survey of 50 barriers and 30 facilitators, and had 197 school staff, teachers, counselors, and principals, administrators fill out that survey with regard to difficulty and impact with regard to the barriers. And we also engaged in concept mapping. So again, these last 2 were related to school staff and school leadership. I'm going to present the results of the school leadership, and just to note that there's a lot of varying kind of perspectives with regard to the implementation. And I wish I had time to go through all of it, but I can't. Okay, so this is a snapshot of what the barriers look like. You can see one common barrier, one very salient barrier was that teachers are resistant to trying new curricula because it feels like one more thing you administrators want me to do in the classroom. And when we looked at the impact and the difficulty of that barrier, we found that it fell within the pretty significant to substantial impact range, and a moderately difficult to very difficult barrier for these particular school staff. And so what we really wanted to do was to understand from a leadership perspective in the DOE, what they thought about the actual barriers themselves and how they might solve some of these things for the school staff delivering the intervention. Yeah. Oh, there we go. Okay. So these are actual people that I covered with cartoon faces to protect their anonymity. But this is a picture of the actual sorting procedure that we did at the Cancer Center and the University of Hawaii Cancer Research Center. And you see the 6 stages of concept mapping up there. For those of you that were in the methods kind of talk earlier today, we went through all of these stages, in terms of what they conceptually mean. But I'm going to be focusing on a couple different ones as I go through the study. So in terms of the barriers, we had the participants kind of rate the extent to which the barrier would impact and how difficult it would be to kind of address the barrier within the school. So we got the perspectives not only of the school staff, but we got that of the leadership themselves. So they rated the 50 barriers, and they also sorted them into respective piles so we could understand kind of what those barriers actually meant to them, right? And so the idea was that individually, the 50 barriers represent, a particular issue that needs to be addressed for the implementation of the curriculum. But together, as we group them together, we're starting to understand how leadership really kind of conceptualized these different barriers into different kind of concepts. That's what we call them. And so what happened after that was we were able to develop a concept map. And what this is kind of a visual representation of those 50 barriers and the extent to which they kind of group together based on the sorting of the individual leadership and, trying to think about how close those particular barriers were to other barriers in their sorting process. I won't get into the technical details around the multidimensional scaling and cluster analysis. Just know that the layers there, how many kind of the thickness of the colors represents how related it is to another kind of concept. So we see that layers related to student attitudes and mindsets, curriculum, and school level buy-in are really interrelated with other concepts. Whereas the kumu controlled, kumu is Hawaiian for teacher, that one is a shallower layer, indicating that those items were typically kind of grouped together independent of the other items in the other concepts. Why is this so important? It gives us a community-based understanding, a leadership-based understanding of how these barriers are conceptualized, and thereby we can kind of address some of the things that were in these particular concepts. And so that's exactly what we did. So we looked at the Go Zone. This is another tool that we did in concept mapping, where we were able to look at this green quadrant. The green quadrant represents barriers that are higher impact, but lower difficulty. There's 8 of them right there. And so when we looked at those 8 items, we were able to see that they mapped onto particular concepts within kind of the leadership's understanding. And we were able to have this very targeted conversation about, well, what do these barriers mean, and how can we address them, and what would be the solution for addressing these barriers? And that is exactly what they did. So they came up with various different implementation strategies that could address some of the issues that we're seeing here with the prevention curriculum implementation. And you'll notice, right, that even though they're kind of grouped based on the concept, they cut across different concepts and they cut across different contexts, right? So when you require more health education curriculum, that certainly impacts teachers, that certainly impacts students, right? So it's not just kind of one level when we're thinking about the implementation strategy, but it certainly gives us an understanding of how we might address these things and what context we need to prioritize in our implementation planning. Just one example, and really, a community kind of driven, community voice kind of example of understanding these implementation barriers. Okay, again, back to kind of our guiding post. The other domain that we like to study is understanding large healthcare systems and contexts to tailor evidence-based practice. So when I say large healthcare systems, I'm also talking about systems that are publicly funded so that your taxpayers pay for. Because one thing, I mentioned to Casey earlier today that I'm very passionate about is making sure that your taxpayer money is being spent efficiently in a public health system with regard to youth mental health. Okay, for this, I'm going to take you from Hawaii all the way to Philadelphia, where I did postdoc, and talk about a study that we did looking at training and consultation in large public mental health systems. So Philadelphia, very big city, and a very big Medicaid population. So I had the privilege of working in the Department of Behavioral Health and Intellectual Disability Services. And they were really charged with disseminating and training a large workforce in evidence-based treatments. They had a lot of, really good, pay for performance money that they were going to use from Medicaid in order to fund that work. And so they were charged with the task of trying to understand, well, which evidence-based treatments are we going to train in, and how do we select the right treatment for our given population, right? And what we knew from a review of the literature was that a combination of both active and experiential training is needed in order to, kind of effect change. It also requires organizational support, consultation, but all of those things in combination are time-consuming and expensive. When you think about the modal therapists in community mental health, they're not salaried workers. They're fee-for-service. They're making money based on the services they deliver. So anytime we're taking a therapist out of rotation in delivering services, we're taking money out of the agency's pocket, we're removing care from the community, and we're taking money out of the therapist's pocket too. So when we think about, kind of training models, we have to really think about the extent to which things are feasible and choosing treatments that are efficient that will address a large population. So what we wanted to do is create a really pragmatic cost analysis metric. We wanted to understand Philadelphia is very treatment developer rich because of the University of Pennsylvania. And so there's a lot of people who have spent lifetimes, their lifetime, Aaron Beck for one, developing treatment in Philadelphia. So it's very resource wealthy in terms of having trainers and people who want to train in the community. So these were these were 7 different, it's in the title actually, of the journal, 7 different evidence-based treatments that had the potential to be impactful in the Philadelphia system. And so what we wanted to understand was what would be the cost of training, consultation, certification, because certification is a big thing, right? You get that shiny paper when you finish a training, and you need that paper in order to prove to Medicaid or the payer that you have the qualifications to deliver the thing. And the time loss, so the wages that you would lose from not delivering services, right, as a therapist. And we amortize that over the number of people or consumers that could be served in a given population. And so that we took Medicaid claims for 1 year within Philadelphia, and we looked at how many people, and we coded how many people for which a particular evidence-based treatment was identified for or tested with. We coded them, and we came up with a denominator of how many prospective consumers could potentially benefit from the intervention. What we found was that there's variability across the board in terms of consultation, but pretty consistent in terms of the amount of training that's needed for any evidence-based treatment. And that's 40 hours, about, give or take. So that means you're taking a therapist offline for a week in order to do any kind of training, right? In addition, consultation, right? That experiential learning, we know that's important. That's another 12 to 50 hours, depending upon, what kind of treatment you're getting trained in. So that means you're taking a therapist offline for a considerable amount of time, not to mention kind of the length of time too. So some treatments you can do the certification and the training process within 6 months. Others you'll need to do it based upon your cases or a whole year sometimes. And the cost is kind of surprising. It's variable. So this is representative of 53,475 unique consumers within the Philadelphia County. And they represent, a number of different kind of consumers from youth all the way to older adults. But you can start to see the total cost includes training, consultation, and time loss. You can see the age range for which a particular treatment has been tested, and how many prospective consumers would benefit from that in Medicaid claims. So just walking through DBT, dialectical, not diabolical, dialectical behavior therapy. Where's your water bottle, Marsha Linehan? Dialectical behavior therapy, $19,000 to train in, very expensive, very effective with a subset of the population, very effective. Age ranges 18 to 45, so mostly adults. Prospective consumers that met criteria for this particular treatment in the Medicaid claims, 81. That means it costs about $238 to train a therapist per consumer, right? Whereas when we start to look at things like cognitive behavior therapy, lower cost to train covers way more of the population, right? Are we saying that you should go with the cheapest? Absolutely not. When we're thinking about a system, some of the things we considered and we talked about with our managed care organization, as well as the Department of Behavioral Health and Intellectual Disability Services, was that there appears to be some kind of tiered approach that you could potentially consider as a system, right? So there are some interventions for which it's going to cover a lot of consumers. Maybe we train a lot of therapists in that one, right? Because we know it's going to cover a lot of different people and it's going to help a lot. And then there seems to be another tier related to kind of trauma-informed or trauma-based treatments. Maybe we want to train a little bit differently there, but we want to train a few agencies in that. And then there's some really expensive ones, DBT and PCIT. There's still a place for those, right? But maybe we don't train everyone. Maybe we look for organizations that can support some of the things that are needed in order to sustain DBT and PCIT. The PCIT, you need a room. DBT, you need like a 24/7 therapist. which I could never be because I have 3 children. But you need certain things, and maybe you find the organization that can do that. Okay, taking you back, we're going back to Hawaii. So I want to talk a little bit more about the work that I started in grad school when Anna and I were in grad school, that really focused on understanding kind of therapist behavior and therapist knowledge. This is what gets me really kind of jazzed up, and probably our team is like, this is the most boring thing that you do out of all the work that we do. So this is a theory of planned behavior. Oversimplification, it suggests that there needs to be adequate knowledge, favorable attitudes, and perceived, behavioral intentions or norms that kind of influence the extent to which you actually kind of change your behavior. And so that's kind of the focal point of some of the research that we did in the Hawaii system of care. And in particular, what I was interested in understanding is, how do we define therapist knowledge? Like, how do we define it, and how do we measure it? How do I measure the amount of knowledge that you have with regard to the work that you're doing? We could probably spend a whole day talking about this. This came out of the work that we did looking at intensive in-home therapists in the State of Hawaii Department of Health Child and Adolescent Mental Health Division, longtime community government partner that we've been working with. And what we wanted to look at was the extent to which certain types of knowledge influenced kind of attitudes. And so there's, at that point in my career, I conceptualized knowledge in kind of 2 domains. Knowledge about specific practices. So do you know that dialectical behavior therapy is derived from the evidence base for a particular disorder? Or the process, that 3-legged stool, right? Do you know how to integrate kind of the general services research, your clinical expertise, and patient preferences in your clinical decision-making? When we're thinking about that jingle problem, right? Like two very kind of related, you would conceptualize, but different types of knowledge, right? And, we're gonna get to that in a second, but they run a continuum in terms of how applicable it is in a therapy room as well. And what we found was that, interestingly, these 2 types of knowledge were not related in this community-based sample. And they incrementally predicted attitudes. So they additively added to the extent to which therapists had more favorable attitudes towards evidence-based practices. Why is that important? Because when we conceptualize knowledge on 2 different domains, we have to train to those things very differently, right? The way that I train you about your awareness of if something is derived from the evidence base or has some kind of empirical backing is very different in the way that I train you in engaging in a process of integrating knowledge. And that's really interesting when you think about it, and has implications about how we go about implementing and training these various types of evidence-based interventions. This is a poster that was presented by, again, Danielle Kara-Ching at ABCT last year. What it says here, I won't go into too much details, is just that we need more pragmatic knowledge measures that give us a good assessment of what therapists already know. Because we know if we're taking them offline for training, we better make sure it's worth their time and that we're giving them what they need. And that's going to be very unique to kind of their personal experiences. So we need to be able to measure that knowledge over time. This now represents my thinking around therapist knowledge. It has certainly come a long way, and probably my team is watching right now and they're like, oh, change the slide. We hear about this all the time. But really, it runs the continuum in terms of procedural to actual declarative knowledge, right? So the extent to which I can verbalize that I know something is evidence-based, to the application of me actually delivering the practice, right? And there's so many different measures that we've been developing to try and understand how to measure that knowledge and then to tailor training in the community. Okay, I promise I'm almost done. We're almost there. You're hanging in there. A couple other things, the two other areas, organizing, synthesizing, and visualizing is existing knowledge. So this is a study that Summer Pasquale and Danielle Carrera-Ching have been leading. It's a mixed method study looking at system usability over time for a electronic case management system that was implemented in the Child and Adolescent Mental Health Division. So the idea behind this electronic case management system, consistent with Center for Medicaid Services, kind of pushing towards all healthcare systems to be electronic by a certain year, they keep pushing back that year, was to kind of revitalize how data was going to be used in the system in order to form decision making. And so what this study did was a mixed method study looking at kind of system usability. So how easy was it to use the system over time? And super important when you're thinking about kind of healthcare systems. Oftentimes, the reasons why we go into the helping profession is not to document notes or put in prescriptions or put in orders, but it's such an essential part of the work that we do, right? The electronic case management system or the electronic health record is here to stay. And if we don't do things that are, meant to train up those behaviors and system usability, we're gonna lose a lot of the workforce. Especially for those who are not, as tech, and tech literate. And so these are the results that are going to be presented at ABCT. So act surprised if you're there. What we found in terms of system usability over time, curvilinear. So we had 3 time points: pre-implementation, 6 months into implementation, 1 year post. And so we see, and much like any other innovation, expectations are high, we implement, it goes down a little bit, and then maybe as things kind of asymptote or level off over time, we see it climb back up, but never fully reaching that, initial kind of, expectation. Super important to consider as we're training out, rolling out initiatives is that, when we start to see these changes over time, and we did find a significant effect for time, site, and time by role, that we need to tailor some of these strategies and these trainings to really kind of understand these contexts. And we see that in our qual themes as well. So when we look at the role group differences, we had open-ended questions, user design questions related to, I liked, what if, I wish there was more of, and we start to see that there are, certain themes related to different roles. And that gives us an insight in terms of how we can kind of tailor some of our tech training, right, to different organizations and different family guidance centers within the system. But that also made us think that there also needs to be a kind of team-based training or team-based solution. When we train in silos in terms of roles or family guidance centers, we're not fully understanding the extent to which our behavior, Alex's behavior, affects my behavior standing in front of him, right? So there's different kind of cascading effects that happen. Sorry to put you on the spot. Cascading effects that happen, and these happen within, large systems and large teams as well. Okay, we're almost there. I promise. We're almost there. Last one. It's providing service and disseminating information to the public. Super important. So a lot of the work that we do, we share, first to community. So all the things that you're seeing related to the case management system, and, you'll hear a little bit about, the Help Your Keiki website. That's all been presented to our partners already. They're hopefully aware of, kind of the work that we're doing. And so that's, a cornerstone of what we do, is trying to share that and provide that information back in the method and the modality that makes sense to them. And so one of the studies that we did in Philadelphia was really trying to understand from youth and caregiver perspectives, what does evidence-based treatment mean to them? And it was really interesting because what we found, consistent with other work like that Sarah Becker has done in substance use, is that the term evidence-based is really off-putting for youth and families. And when you think about evidence, when you ask them to define evidence, they almost always go to forensic evidence. Evidence that's going to be used with, against me, or evidence. So it's never about the scientific kind of merit. And so that's a lexicon problem again, right? But that's our problem as researchers or as trainers to really kind of understand that language. And so, that's another cornerstone of the work that we've been trying to do, is really trying to get information out there to youth and families, to therapists, in a way that's actionable for them. I'll quickly go into this. Just want to make a quick note. The Society for the Science of Clinical Psychology has an interview series with prominent clinical psychologists. What we tried to do in this study was understand if we condense these interviews into 2-minute increments or less, will we increase the uptake of the actual interview? So we did, we made all these YouTube videos. I'm really bad at these things, so a lot of our research assistants did this. We made 2-minute clips. We disseminated it on Twitter, and listservs, and we tried to understand, and this is work that Tessa Palafu has been working on. We tried to understand kind of the extent to which those modalities would reach the audience. I won't go into too much detail about that, but just note that in terms of the actual YouTube videos, it did increase the views of the videos and the traffic on the website, which suggests, right, when you make videos like this, interviews, and you put it on a website, you think, there, I'm done. There it is, have it. But what we found in this study, right, is that you need ongoing dissemination support, and you needed to do it in ways that are accessible, especially to therapists, in order to get them to come back. So the percentages represent, in that time period, we did a 3-month time period of a targeted dissemination effort, how much of the total views on the website came from that time period. And so you can see almost close to half to almost half of the traffic happened during that targeted dissemination effort. Super important, right? So we can't just make things and leave it and expect people to come. That field of dreams issue. I like field of dreams, what's that? Okay, last one, I promise. This is the Help Your Keiki website. You can scan that QR code. The Help Your Keiki website is meant to increase youth and caregiver knowledge of evidence-based treatments. And so a study that Tessa Palafu is working on, super excited about this one. This one is so cool. She's doing a think aloud and an interview on the website, having parents navigate the website and share their thoughts about it. And what she's learning is that a lot of the things that parents want in a website have more to do with the aesthetics than the content itself. Makes sense, right? You as a person go to a website because it might look good or it might speak to you. Not a lot of info or criticisms or thoughts on the actual content. And that, has implications about how we disseminate some of the information to youth and families. Okay, I promise I'm done, but I'm not done. All right, here's a picture of Maui and Lahaina. I would be remiss if I didn't take the quick moment to recognize just how devastating, that was for our community. This excerpt is from something that our team pivoted to in August, I believe, for an entire month supporting the State of Hawaii Department of Health in their effort to address the behavioral health needs of Maui post-wildfire. And so we were charged and were asked to help develop a grant application that would build a community resilience center. Do we know a lot about community resilience centers? Absolutely not. Did we have time to learn? Absolutely not. So we tried our best. We looked at previous disaster literature, previous, talked with people who have worked in disaster mental health spaces. You'd be surprised how many experts there are in disaster mental health, and really started to conceptualize kind of this idea of building a resiliency center that was grounded in the community. And with government, we always have to conceptualize what that structure looks like and what the kind of power hierarchy is going to be. What we were super excited about writing of this grant is that it was going to be community led. So the community resilience, all the tiered interventions that were developed in this community resiliency center were born out of kind of a community-based intermediary organization that would be kind of the voice in order to kind of elevate some of the needs of Maui and their people. So super exciting. Brian Schott got to announce this because he did absolutely zero writing on this, but he got to do, release the press release on October 4th that we were able to secure over 17 million for the state for this. So we were really excited. So just a quick kind of last note in terms of implementation science and implementation research. I can 100% argue that all of you are thinking about implementation, and you almost always need an implementation researcher on any project that you're doing, because we have to do more with what we already know. We have so much information out there that we need better tools to synthesize that knowledge. And we really have to strengthen our common language and tackle that lexicon problem. We have to think about that jingle and jangle problem and how we're going to really make tools efficient and make our language clear and plain and simple in community's voice. And we also need to develop an implementation evidence base that's community-led. Oftentimes, when we think about implementation, it's from the top down. It's a researcher coming in, it's leadership coming in saying, this is how we're going to implement it. We need community to tell us how to implement it. Awesome. Just a quick note to these 3 rising scholars that I extend so much gratitude to every day, Danielle, Summer, and Tessa. Danielle and Tessa are on a plane right now to Seattle. I think Summer's watching probably. And a quick note of a couple other collaborators, community members. I'm on the Twitter, but I'm never actually on it. That's my email. Some of the funders. And a quick note, we're hiring. So if you know, anyway, in particular, we're hiring 4 postdocs. We will be hiring potentially a research assistant in January. Please scan the QR code. We would love to have you. Awesome.
Okay, thank